Today, welcome to Grand Rounds. We have Dr. Amrine here, one of our chief residents, talk about dialysis and pregnancy, two words that should never go together.
So, like she said, I'm Dr. Amrine, and talk on dialysis and pregnancy today kind of was prompted by our recent patients that we've had up on the labor units that were pregnant. I think one was pregnant before she started on dialysis, and then the other was actually on dialysis, I believe, before she became pregnant. So today, what we're going to try to do is identify the issues involving end-stage renal disease, dialysis, and how they relate to pregnancy, establish some of the basic principles in the management of pregnant patients that are on dialysis, and then review the maternal and neonatal outcomes so we can better counsel our patients that we have in clinic or on the labor unit that are in this predicament. So I don't know about you guys, but when I walk into a room, either when they come down for dialysis or up in the MI, this is kind of what I think when I walk in. It's really complicated, and this is what I would label the things on the machine. So unfortunately, today's talk isn't to orient you with the actual machine. So we're going to talk a little bit about the background of dialysis and pregnancy, go over some of the fertility issues that are involved that kind of make this a unique topic, the basics of dialysis, the effects of dialysis on the pregnancy, the management of the pregnancy itself, and then again the outcomes, and then try to summarize a little bit so when you leave today you kind of have an idea, if you get asked what we would recommend, you can give some of the basic recommendations. So this is a rare occurrence that we get pregnant patients who are on dialysis, and looking at the numbers, there's been a couple different reviews of institutions, one of them being in Belgium. They looked over a 20-year time period at 22 centers, and just women that were of childbearing age on dialysis accounted for only 18% of their patients. There were two surveys done actually in the US that over a 2-year time period, they found that 1.5% of the women that were of childbearing age became pregnant when they were on dialysis. And then another looked over a 4-year time period, and they found a very similar number, about 2% of these women became pregnant while they were on dialysis. In 1971, every study that I looked at, this is like the landmark case for pregnancy and dialysis, because this was the first time it was actually documented that someone on dialysis was pregnant and successfully delivered a live-born infant. 2005, though, is actually the first time there was a prospective study looking at the dialysis management and the outcomes of pregnancy. Everything else has been retrospectively done. A lot of that has to do with the rarity of pregnancy in these patients. So just to remind ourselves of some of the physiology of a normal pregnancy, we have an increased protein content, and this comes in the maternal blood, the fetus, the placenta, the uterus. And this is important when relating to dialysis and the fact that the protein is going to be more difficult to quantify in a patient on dialysis. We have an increase in the blood volume already in a normal pregnancy. This leads to a physiologic anemia, which again comes into play for dialysis patients. In a healthy patient, there's actually an increase in the kidney size and also the cardiac output to the kidneys, increasing our GFR from 25 to 50% over the baseline. And then the acid-base changes that occur in pregnancy, a lot of times we don't think about all that much, but in the patient on dialysis with renal disease, this can become a little more complex. As you remember, you have a respiratory alkalosis with a metabolic acidosis to try to counteract this. And on dialysis, that can be exacerbated even more. So when you look at the changes in end-stage renal disease and how these relate to pregnancy, again, anemia in these patients is very common, and they believe the underlying pathology for this is due to a resistance to erythropoietin. A markedly elevated BUN is pretty obvious. Their kidneys aren't functioning, but we'll talk about this later in terms of the outcomes of pregnancy. This has an implication. Hypertension can become a little more difficult to manage, and it becomes more common in patients on end-stage renal disease. And then decreased fertility in general. Thus why this is not a very common occurrence and we don't see many patients on dialysis. So looking at the causes, it's very rare in women of childbearing age to have this, but the ones that are found to have end-stage renal disease are usually chronic glomerulonephritis, interstitial nephritis, lupus nephritis, which we see a little bit in our clinic, diabetic nephropathy, which is becoming more prevalent with the prevalence of diabetes in children, and then hypertensive nephrosclerosis, which is also probably going to be increasing as we see more kids with hypertension because of obesity. So Okunduyai, I think I'm saying it right, did a study in 1998 looking at the registry of pregnancy in dialysis patients. They surveyed almost 2,300 dialysis units in the US. They only got 930 to respond. In these 930 centers, they found information on the primary renal disease of 121 pregnant patients. So you can see not very many. And looking at the breakdown, this is, you can see the primary glomerular disease, and to refresh your memory back to studying for step 2, you have like minimal change disease, membranoproliferative, rapid progressive glomerulonephritis, focal segmental, all of those fall in this category. Lupus nephritis, it was very common in these patients. And then one that I want to point out that doesn't seem so obvious, but interstitial disease is one that stood out to me because when I did my nephrology rotation, my nephrology attending would get on a soapbox every time we had a patient on Pepsid who didn't need to be on Pepsid for GI prophylaxis, because he said he would see more cases of acute kidney injury and interstitial nephritis from patients who were incorrectly put on GI prophylaxis from a basic medication, because it is one of the side effects of it. So it's always something to remember when we're prescribing medications to otherwise healthy patients, that we can have unintended consequences. So the fertility is the other issue in these patients. It's affected in a couple different ways, but the biggest thing we'll see is there's irregular menses, and this is associated with patients' GFR less than 15. You can actually become amenorrheic when the GFR drops below 5. They're often, when they do have a cycle, they're anovulatory, and these are due to some of the endocrine changes. These patients usually are very anemic. Like I said, most of these patients in the studies were about 8 to 9 was their hemoglobin. And if you think of most of our patients start out in pregnancy about 10 to 11 in our population. Endocrine changes, the one that actually remains the same is the FSH. You can see an elevated LH, but there's actually no surge despite the fact it's elevated. And part of that's due to low estrogen and progesterone and elevated prolactin. And this was found back in 1980. Lim and colleagues did a study looking at the ovarian function in patients with chronic renal failure and looking at the hypothalamic process as the cause of anovulation. And so what they did is they took patients who were of childbearing age on dialysis, compared them to postmenopausal women who were also on dialysis, and then had a control group of childbearing women who had normal menses and hadn't been on any birth control for at least the last year. And they looked at their FSH, LH, estrogen, progesterone, and their prolactin levels. And it wasn't a very big study in terms of the patients they had. However, when they looked at the hormone levels, the significant values were the LH and the prolactin were elevated in the premenopausal patients with chronic renal failure compared to the normal controls. And as you can see, the normal controls showed your typical LH pattern from follicular to mid-cycle to the luteal phase. And if you look, that I thought was interesting, and they don't really point it out in the study, but the premenopausal and the postmenopausal numbers are very similar, suggesting that these patients are pretty much in a menopausal state, and that's part of the reason why their infertility is so low. Also, that they found in this study, 10 of the patients in the premenopausal group were completely amenorrheic. So 10 out of the 17 had no cycles whatsoever. So let's move to the dialysis part, back to the basics. So what it is obviously we all know it's an artificial way to remove waste from the body in patients who have failed kidneys. We have hemodialysis, where we're actually using an AV shunt to take the blood, run it through the machine, and put it back after it's purified. Then there's the peritoneal dialysis, which is a little more intensive in terms of the patient at home, using a catheter that goes into the peritoneal cavity, flushing dialysate into it, and then it draining out after the equilibrium has happened. It is through an osmotic process, through a semi-permeable membrane. So again, you have the blood from the patient with all the waste, and over time, it goes across the semi-permeable membrane. These are just schematics of showing the basics of hemodialysis and peritoneal dialysis. Again, you can see we have the membrane, and usually there's a countercurrent flow, which I'll demonstrate in a minute, which helps this process occur. And then this is kind of a diagram of how patients on peritoneal dialysis actually are hooked up. As you can imagine, in pregnancy, this isn't a very good option, especially later in pregnancy, is you're not going to have this much extra room at a term pregnancy for the peritoneal dialysis. And this is a little bit more complex, but it shows the process of the hemodialysis and all the parts that are involved, including a heparin pump, which is something that we have to remember, or really the nephrologists need to remember when they have these patients. They do adjust the heparin dosing a little bit to hopefully not interfere with any of the pregnancy. So I have this little schematic I found that for those of us that are a little bit more visually impaired or visually inclined, just kind of the basics of how it goes. So here you can see there's a counter current, and this keeps fresh diacylate always meeting the blood, pulling solute and water across the membrane. And this is done simultaneously. And then obviously the blood's returned back to the patient. So this to me just was kind of a nice quick little reminder of how this works and kind of puts it into a visual perspective. So looking at the effects on pregnancy, a patient's more likely, even though it's still rare, to become pregnant if they have any residual kidney function. So a patient who may be on dialysis but still making urine, they're the ones that we definitely have to think of if we see them in our GYN clinic about possibly getting pregnant. The delayed diagnosis due to these patients' irregular menses is an important part. And there's a couple of studies that pointed out that the first diagnosis of pregnancy was about 17, 18, 20 weeks. And which is kind of late when you consider these patients are usually seen 3 times a week for long periods of time. And again, if they're not making urine, there's no real good way to test it other than maybe running an HCG. Polyhydramnios is very common in these patients. The actual cause isn't fully understood, but there's a couple hypotheses. One being that the maternal plasma volume increases so much beyond the normal pregnancy levels that it will cause the fetal plasma and urine output to increase. The other is suggested by the elevated BUN, and that there'll be a fetal solute diuresis, and that will create more amniotic fluid. And there's a study I'll go over in a little bit that actually shows the correlation between that, between the importance of the BUN level. The hypotensive and hypo-perfusion that can occur to the uterus and the placenta is something that needs to be recognized in these patients as they're pulling large amounts of fluid off these patients, taking their blood pressure sometimes from 180s to 140s. That may be enough to decrease the perfusion. Hypertension is difficult, or it can be exacerbated in these patients, especially a lot of them have chronic hypertension to begin with, and then if there's any development of preeclampsia. And then achieving the appropriate weight gain in the mom. How do you measure the patient? When do you measure the patient? And then decide the weight is being gained due to the pregnancy and it's appropriate, or is it due to fluid overload and needing more dialysis? And that's one of the very tricky parts when managing these patients from the nephrologist standpoint. Anemia gets much worse. Like I said, a lot of these patients start out at about 8 to 9. And a lot of our pregnant patients, when we see them for the initial OB visit, are starting out at 10 or 11. So if you exacerbate the anemia from pregnancy and the dialysis, you're looking potentially at some problems. And then diagnosing preeclampsia, as I mentioned, hypertension, is it due to the fluid overload or is it due to the process of preeclampsia? And then how do you diagnose it without any urine to measure protein? So a lot of it is based off your clinical findings and the blood pressure readings to diagnose preeclampsia in these patients. Then prenatal screening, this was one of the topics that came up as we were dealing with one of our patients, is there an effect of the dialysis on the hormone levels that we need to measure for prenatal screening in the first and second trimester? And there actually is some evidence to show that the beta-HCG level used in first trimester screening can inversely be correlated with the creatinine clearance in these patients. So that's something to remember, that if you get an abnormal reading in a prenatal screening test, that it may be due to the end stage renal process or the dialysis. It may not always mean that it's a fetal problem that's going on. So when we're managing these patients, it's very difficult to come up with a consensus. Because of the rarity, there's little prospective data and no randomized trials. So there really isn't one better way to do this per se. Most of the recommendations are all on what has happened in the past with pregnancies and what were the difference in their dialysis management. Nephrology, they all have a general consensus for the most part. However, the intricacies of each patient need to be taken into consideration, that some of the management recommendations may not be feasible or may not be appropriate for patients. From the OB standpoint, a lot of it's based on the usual maternal fetal indications. However, there are some special in terms of intervals of growth ultrasounds, BPPs, electronic fetal monitoring that need to be considered when managing these patients. So the prospective study I talked about that was done in 2005 was done by Haas and colleagues. They did this in a single site center, and what they did is they developed a systematic approach using an intensified hemodialysis protocol. And so they decided that this was going to be their protocol. Every pregnant patient that came in was going to get this, this protocol. And a lot of it was based off of a lot of the current recommendations at the time from the retrospective data. So they did a minimum of 24 hours a week of dialysis for these patients. They standardized the diastolate medium so they didn't have differences between patients. They targeted a hemoglobin greater than 9, and the way they achieved this was using erythropoietin, IV iron, or PO iron to keep their hemoglobin above 9. They did a standardized diet as best they could, but also did a replacement of vitamins and water-soluble vitamins, especially the B vitamins, are removed during the dialysis process. They did an ultrasound every 10 days looking at MCAs, umbilical artery, Dopplers, biometry, cervical lengths, and the AFI. And then electronic fetal monitoring when patients did have to get admitted to the hospital. These patients were actually managed in an outpatient setting unless there was an indication to put them in a hospital. And then tocolysis and steroids for fetal lung maturity if it was indicated. So from over the 4-year time period that they did this, they had a total of 5 pregnancies. They were all managed in their clinic. One of them had conceived actually prior to the initiation of hemodialysis. 4 were already on dialysis. And the one that conceived prior, the reason they put her on dialysis was due to the BUN levels and the creatinine. And so they decided that it would have been better overall for the potential outcomes to start her on dialysis. The gestational age at which the diagnosis was almost 18 weeks average in these patients, which again is, you would think for these patients getting seen 3, 4, 5 times a week, that would easily be diagnosed in these patients earlier on. They actually had an average hemodialysis per week of 28 hours, which I would imagine these patients were pretty much hooked up to the dialysis machine the entire time. They had a BUN decrease of 94 when they initiated the protocol to 36, a creatinine decrease from 5.3 to 2.8. Their hemoglobin levels, which I found was quite interesting, went from 8.9 in initiation to 10.7. And again, I put this as, you look at some of our patients who are healthy, come in their term with a hemoglobin of 9. And these patients are getting, they had their patients up to a 10, and they shouldn't normally be that high due to the underlying disease process. The mean gestational age was almost 33 weeks and 1,700 grams, which is significant, as that's above the very low birth weight in the very preterm, which comes with a lot of comorbidities in these neonates. 4 of the 5 delivered by C-section, and all 4 of these developed ARDS. And then the average hospital length of stay for these newborns was almost a month, 26 days. So here's an actual breakdown of the 5 pregnancies that they had, and they did do a follow-up. However, they didn't define what healthy was in these patients, which would have been helpful to understand exactly how healthy some of these patients were. But as you can see, the one patient was delivered at 30 and 4, even with a weight of 1,274 grams. At 5 years, still had follow-up, and they were considered healthy based on the pediatric records. And you can see that only one patient actually made it anywhere close to term at 37 and 4. And that's a very common finding in a lot of these studies retrospectively. So what they concluded was this intensified hemodialysis treatment may be useful in terms of the future in guiding patients and nephrologists on how they should be handled when they become pregnant. And again, this was a lot of their protocols based off previous guidelines that had been developed, but it was a little bit more intensified with fairly good outcomes. So Holley and Reddy in 2003 also reviewed what's the management or what's the best management in these patients. So what they did was they designed a retrospective review of reports of pregnancies from 1992 to 2003. And what they found and concluded was that an increasing dialysis dose increases gestational age and birth weight, very similar to the last study I just showed you. The 20 hours a week, according to their study, was non-significant in difference. However, there was a trend towards improved fetal survival. BUN less than 50 was the common finding in a lot of these studies with surviving infants at birth. They also noted that more frequent hemodialysis. So instead of maybe doing Monday, Wednesday, Friday dialysis, doing 5 days a week for 4 to 5 hours to reduce the amount of fluid shift. A lower bicarb concentration was noted, and again, that goes back to the acid base, normal in pregnancy, but if you're adding bicarb during the dialysis session and you're making them more alkalotic, then they have to try to respond metabolically with the acidosis, which they can't because the kidney function isn't there. The maternal BPs diastolically should be kept below 80 to 90. The unrestricted protein intake was a general consensus in most of these studies, which is something you wouldn't normally think of in a patient on dialysis who can't process the protein as well, but it may be due to the needs during pregnancy as well as the removal during dialysis. The erythropoietin dose was increased by up to 50% in most of these patients, and that sometimes can be a concern, as a lot of people think, well, is there complications with erythropoietin in pregnancy? It's actually been well established, the safety of erythropoietin in these patients with no effect on the actual fetal development. And then close OB follow-up, of course, is one of the findings they found with looking at the fetal growth. They mentioned uteroplacental flow, but don't really define how to do that. And then early assessments if there's any fetal complications, so it can be dealt with appropriately. So this is what their guidelines came about, and the common theme that a lot of these have is 4 to 6 times per week after the first trimester, these patients are going to be on dialysis. And I think I know for sure that one of our patients, she was getting it 5 days a week, and occasionally would get a weekend on the holiday, but still had to stay in the hospital. The hemoglobin levels here, they recommend to be 10 to 11, and again, it usually requires the increase in erythropoietin. And a folate of 1 milligram per day, especially early in the pregnancy, which I think would be more helpful if they were counseling their patients who are of childbearing age to be on that already instead of waiting until after a pregnancy is diagnosed at roughly 18 weeks. And then obviously the blood pressure control. So again, a lot of people have looked at this. This is another one that I found I thought was useful. Cannot pronounce the name, but it was done in 2011. And they looked at pregnancy and end-stage renal disease. And what they did is they reviewed the issues involving pregnancy and end-stage renal disease. And they looked at what was called the Toronto Pregnancy and Kidney Disease Clinic Protocol for Management of Intensive Hemodialysis, or the pre-KID clinic protocol. And what this came about is this protocol had several different areas to look at and try to follow. First was the fetal assessment, looking at first trimester routine screening. And this is actually the study that mentioned the possible abnormalities in the first and second trimester screening due to the hemodialysis and the end-stage renal disease, but they still recommend getting it in the first and second trimester. All these patients should get a level 2 ultrasound as well as cervical lengths and screening for a fetal anomaly between the 18th and 20th week. The cervical length being that preterm labor is very common in these patients, and one of the other studies I'm going to go over will show you how common this is. They also mentioned Doppler studies, the placenta at 22 weeks, and then weekly BPP and ultrasound starting at 26 weeks until delivery. In terms of the nutrition, again, mentioned that multivitamins, the water-soluble vitamins, are very important to replenish in these patients, and they actually recommend doubling the dose of multivitamins. Folic acid here, they say 5 milligrams a day, a little bit more than the previous study. An unrestricted diet, they didn't keep these patients on a certain diet, low sodium, low, and things like that. And then at least a daily protein intake of 1.5 to 1.8 grams per kilogram per day. And then more in terms of the nephrology and the dialysis standpoint, but something to be aware of when we're looking through labs and may see something abnormal is adding potassium when they're doing the diacylate. The bicarb, as I've talked about, is important. It's a little bit lower dose than the normal. Using calcium and sodium phosphate to help maintain maternal bone health as well. The anemia is again probably going to be managed more by the nephrology team, but it's something we need to be aware of and recommend if we see some of these patients and notice what their hemoglobin levels are. But they actually had patients on IV or oral iron for the stores, and then the erythropoietin regularly. The volume status, which can be very complex to figure out, and something we'll never actually be asked to do, thankfully. But they did it monthly and then weekly to be able to figure out what the maternal volume status was, and was it normal for the pregnancy, or is it due to fluid overload from inadequate dialysis. Then the hypertension, again, a little bit more strict than what we usually recommend, sometimes even for our chronic hypertensives. A 140 less than 90 is what they recommended. And this is usually post-dialysis, as the pre-dialysis is probably going to be a little bit elevated due to the fluid overload. So that's kind of the basic management guidelines, but the outcomes. What can we expect for these patients? It varies between most of these studies. A lot of it has to do with the such few patients that are in these studies. There is no prospective data again, so it makes counseling these patients. How do you counsel a 21-year-old who wants to get pregnant but already on dialysis about their potential outcomes of pregnancy? And then is it really an effect of the end-stage renal disease, the dialysis, or are the outcomes more based on the prematurity when it comes to the neonate? There's more recent studies are starting to show that it's more the prematurity as opposed to anything actually doing from the dialysis part. And then obviously you have to be in a multidisciplinary setting. You can't be doing this in an area where you may have a nephrologist 50 miles away doing the dialysis and you're a generalist trying to manage the patient, which is one of the issues we had with one of our patients on the service not too long ago. So who is one of the, I would say probably more authoritative figures in pregnancy and hemodialysis, because the name shows up on a lot of the studies and seems to be the recurring person that's done a lot of looking into this. Did an analysis of the frequency of outcomes in pregnancy in women on dialysis. What it was a survey of 206 dialysis centers in the U.S. They had, in this patient population, almost 1,300 childbearing age women who were on dialysis. Only 60 pregnancies were reported, and the outcomes that they had were, as you can see, only about 37% of pregnancies ended up in a surviving infant. Most of these ended up in a spontaneous abortion, and then the 8% elective abortion is fairly low when you compare it to the late 70s, early 80s, and starting into the later 80s, where it was actually commonly recommended for these patients to just get an abortion therapeutically because they were on end-stage renal disease and on dialysis. And then they had a couple pregnancies that they had no outcomes on. So they broke it up when looking to see if there's a difference possibly in time based on the management of dialysis in these patients. Prior to 1990 in this study, only 21% of the patients had a surviving infant, but after that they had a 52%, but they didn't dive into what may have been the actual underlying reason for that. When they looked at the type of dialysis these patients were getting, most were on hemodialysis, and only about 42% had a surviving infant. They had 7 patients on peritoneal dialysis. 5 of them had a surviving infant, but when they looked, it looks like a major difference, 42 to 83, but statistically it wasn't significant. And then it was interesting that they found that patients who were on erythropoietin compared to patients who were not had no difference in the surviving infant outcome in this study, which is contrary to what the recommendations are to help improve the outcomes. The maternal complications weren't complete in the study, so they couldn't actually quantify them, but the ones that were reported were pretty major and can be very significant. Malignant hypertension, hemorrhagic complications, placenta abruption, postpartum hemorrhage, DIC, respiratory failure, DK, and then sudden infant death syndrome. So none of these are anything that you want to encounter on a regular basis, but especially a patient who's already very sick and on dialysis. The gestational ages were only reported for about 19, or were only reported for 19 of these pregnancies. Only 1 actually reached term, and they had 4 that were born prior to 28 weeks. So, and 2 of the neonatal deaths in the study were from these 4. The birth weights, they only had 15 reported on the survey. They had about 3 of them were below the 10th percentile when they were born. So this came in terms of the discussion, and the conclusion from the study was that there was an increasing infant surviving rate for patients that are on renal replacement therapy over time, which is a good thing, but they didn't actually explain why that might be. The contraception counseling should be very important in these patients, especially when we see them maybe in the GYN clinic to do their pap smears. Even though the frequency of pregnancy is only about 1.5%, I'll show you on the next slide that just because the patient's been possibly on dialysis for even up to 10 years, they can still get pregnant, and a lot of times it's just thought that, okay, they aren't having periods, they have irregular periods, there's no way they're getting pregnant. Prematurity was the most important factor in the outcome of the neonates. And then obviously there's serious maternal risks that are associated potentially with these patients getting pregnant and making it to delivery. So here you can see, this is a look at the 42 of the pregnancies that they had data on. That most of them that were on hemodialysis were pregnant within the first year that they were on dialysis. But here you can see the second highest category. These patients were on dialysis for more than 10 years and still became pregnant. So I would imagine there was probably plenty of time to counsel these patients on contraception. And obviously, whether it was desired or not, they didn't go into that, but that's an important point to consider. So I've talked about the BUN level and the importance in the outcomes in pregnancy, and this was probably the best study I could find that actually looked specifically at BUN and the outcomes. And what they were looking at was optimizing the birth weight and gestational age. And this was done in Japan by another name I can't pronounce in 2008. And they did a retrospective study of 33 pregnancies that they had at their center that were treated between 1986 and 2007. So again, almost 20 years, they had 33 pregnancies, not a large population. And what they wanted to do was compare the pregnancies that were successful, defined as a live-born infant, compared to ones that were not successful, so meaning they either had didn't make it to the point where they got to viability or miscarried. So they had actual data on 28 of the pregnancies that they could look at. They had, in their study, they had a 64% survival rate at 1 year, which is much, much higher than the previous study that was done in 1994. But they had 22 of their deliveries were preterm. 50 of these were actually due to advanced preterm labor, not for fetal or maternal indications. So when I talked about getting a cervical length, that's one of the potential reasons why is maybe catch patients who are at increased risk for preterm labor. And then they had a 37% C-section rate, with non-reassuring as the most common cited, not because of the fact they were on hemodialysis. I did realize this is going to end up so low, but here you can see their outcomes over all of the pregnancies. They had about a 14% spontaneous abortion rate, much different than the other study where they had 44% spontaneous abortion rate. They had 1 stillbirth, 3 neonatal deaths, and 2 infant deaths. So again, just because these patients may get a live-born infant, there are still some potential complications for the infant. They broke it then down. They didn't actually say why they looked at 86 to 96 compared to 97 to 2007. But in this study, they didn't find a difference in the successful pregnancy outcomes. They were, or the birth weights or the gestational age, even though 31.4 and 26.4 seem to be quite a difference. Statistically, these weren't different between these two time periods. The maternal outcomes, I've mentioned the hypertension is important and can be difficult in these patients. Of the 11 patients who had hypertension prior to pregnancy, 8 of them ended up having to get started on medications that previously weren't. And then 9 of 21 of the infants that were born and documented complications neonatally had birth weights of 932 grams was the mean birth weight. So again, the prematurity aspect probably plays much more role in the neonatal outcomes than being on hemodialysis itself. This is a graph of their birth weights. The circles here are the successful pregnancies, and then the squares are unsuccessful. As you can see, they actually had a pretty good following within the standard deviation of birth weights throughout their pregnancies, but they did have some that started to fall off. When you're looking at the complications, I mentioned earlier about polyhydramnios being a major complication, possibly one of the factors of why preterm labor may be so common in these patients. 40% of them had polyhydramnios. So again, we need to be monitoring these patients' AFIs when we have them on our service or see them in our clinic. Hypertension, again, 40% of these patients had hypertension. Looking at the neonatal outcomes, I highlight these 4 because they were the more common ones, but retinopathy, respiratory distress, patent ductus arteriosus, and chronic lung disease were the 4 more common ones that were found when it came to neonatal complications of the study. So what they found, so then what they decided to do is, okay, what blood markers or what can we look at to see may predict our outcomes, and what should we set our goals at? So they looked at the hemoglobin in successful pregnancies. It was 9.6 compared to 8.3. The BUN, though, 45 compared to 66.9 for non-successful pregnancies. And the serum creatinine was still fairly elevated in these, between the two groups. So they looked and did a linear regression to see if there was an association between the maternal clinical and biochemical markers and the birth weight. And what they found was a birth weight of 1,500 grams was correlated with the BUN of 49, and 32 weeks correlated with the BUN of 48. And looking at the 2 models here, you can see the pregnancies plotted, and at 1,500 grams, and again, I've mentioned 50 has been most of the goal, or the goal in most of the recommendations. They were right at 49, and then the gestational age of 32 weeks fell just below the 50 for BUN, indicating that the uremic or the azotemic environment may be what is a predictor for the outcomes in these pregnancies. And this can be influenced by the hemodialysis, which is why you see a lot of the protocols or recommendations recommending 24 or more hours per week. They also then, obviously it goes, if you have a further along gestation as well as a bigger baby, your neonatal outcomes are probably going to improve for these patients. And that the goal pre-dialysis, not post-dialysis, should be less than 50 for a DUN for the best neonatal outcomes. And then again, how, like I said, there's a lot of these type of retrospective studies. Wrote a paper called The Modifications of Dialysis Regimens in Pregnancy. And what one of the things that was stated was in a review from the National Registry of Pregnancy and Dialysis Patients, there were 58 questions or 58 responses. And one of them was the average time spent on hemodialysis and the outcome of the pregnancies, successful versus not successful. And what they found was, again, that the 20 hours a week that was implemented is where they actually saw increased infant survival. And here's the actual numbers. You can see 77% of pregnancies who had more than 20 hours a week had successful outcomes. This is just showing it again, that anywhere between 9 to 20 that they looked at, you're still looking at a very low successful neonatal outcome compared to the 20 hours a week or more. So in summary, to try to bring us back to kind of what do we do as the obstetrician, what are some of the recommendations? Remember, this is rare, so we're not going to see it a whole lot, but the frequency may actually be increasing, especially I'd imagine in 15, 20 years when a lot of the current 10, 11, 12-year-olds who are obese, hypertensive, diabetics are going to be in their reproductive years. How many of them are going to be chronic or end-stage renal disease? The guidelines vary between recommendations based on the studies, but a lot of them have common themes. 20 hours a week of dialysis, and this is one of the things that I talked with a resident on nephrology one day about, is we both at the time were unaware of what the recommendations were on a lot of this stuff. But they were doing the right thing. They had the patient on dialysis, I think, for about 22 to 24 hours a week. The frequent monitoring for the growth, NSTs, BPPs, especially for the AFI, are important. Increasing the water-soluble vitamins, doubling the dose in some cases, having probably any of these patients that come in who are childbearing age for maybe their annual, for their pap smears, STD screening, starting them on folic acid, as well as contraception management. There really shouldn't be a restriction on the diet for the maternal nutrition. It hasn't been shown that a certain diet has better outcomes. And then a goal BUN less than 50 before the dialysis session. So they should be getting dialyzed enough to where in between sessions their BUN stays less than 50. The complications are common and can be very significant both on the maternal and the neonatal side. And then again, you should not be trying to manage these patients if you're not in a multidisciplinary tertiary center where you have a neonatologist, a nephrologist, an MFM that are capable of helping manage these patients in concert. These are my references, and any questions?
That was excellent. You did a very good job with that in a very difficult subject, something that we do not see frequently. I think you might want to reiterate the management of these patients from an obstetrical perspective.
Yeah, that was kind of the hard part to find, but from what I got from the obstetrical management was pretty much very routine in terms of these are high-risk patients. You need to they're increased risk for like IUGR, so the growth needs to be monitored, the AFIs especially. Yeah.
Preterm birth.
Preterm birth. Yeah. Especially when they're not on our floor.
That's right.
Would you suggest putting them on progesterone then, if there's that? I mean, you're never going to have a study that's going to look at that.
Yeah, I mean, I don't think that.
Giving them steroids at 24 weeks.
Burn chicken feathers.
Well, I think part of it, I want to say, showed getting like the cervical length at around 18 to 20 weeks or 18 to 22 weeks may help guide that if you have a patient who has a cervical length of 2.6, 2.7, right on the borderline for repeating it. And it may help in terms of management as you get closer to viability.
Point is, these patients go into labor easily.
Yeah.
So that was very good, Amrine.
I don't know enough about dialysis and medications, but if we're suggesting, like, obviously some of these women can get pregnant, are birth control pills a viable option if they're being dialyzed 5 days a week?
No, they aren't. And the reason is because the efficacy decreases greatly on these patients. They even mentioned that there was, I looked through a couple of things that were talking about that, and even Mirena and Nexplanon can have decreased efficacy because of the increased clearance of the birth control hormone. So I think one of the ones I saw was the copper IUD is probably the best option for these patients. And it is important to remember that these patients aren't going to stop having intercourse. In fact, a lot of them, I think it's like 80% in one study, they were having a normal sexual interactions with patients. So it may be thought that...
In between dialysis?
Yeah. So hormonal birth control is probably not the best option for these patients. And they need to be counseled if that's what they want, that it may not be as effective compared to someone that's not on dialysis.